Let's start with a monster. If you were here yesterday, you would have seen the monsters that were in the room. And after that, I'm going to show you the most beautiful woman in the world you're going to ever meet. And at the end, I'm going to link it all up to how this links to psychedelics. So let's go. And the first thing to say is that for cannabis in general, we're never ever taught anything about this. But the truth is somewhere out there. And I think I found it a little bit. You can decide who's Mulder and Scully between us, but we'll get to the truth as well. And the truth is involved in this. So who of you believe in the Loch Ness Monster? Have we got? Oh, there's a few votes there. Yeah, it's definitely about. And if you believe, or when I was a child, I used to watch this program a lot, and I loved it. It was a family nest, and in the background there, you can see a little castle. It's the Urquhart Castle. I've been there. It's beautiful. You've got to go. But what they also discovered in Inverness was that there was a Loch Ness Monster, and she is the most beautiful woman in the world. And here she is, and that's her. And what happened was, one of my anaesthetic colleagues, what they did was they put her to sleep. And while she was asleep, she didn't need much anaesthetic. And when she woke up, she didn't need much pain medicine. And this confused the anaesthetist. It's really hard to confuse an anaesthetist, as you can tell, right? What's going on here? How did that happen? So she rehabbed very quickly. She woke up. She went to the physio. The physio got her out of hospital within a day or two, which is unheard of. And so he's just like, something's funny going on here. I need to send her to University College London so they can look at her. So off she went. She went to University College London, and they did loads of genetic profiling on her. And what they discovered with her was that she was unable to metabolize anandamide. And anandamide is one of your endocannabinoids. Okay, she just had loads of it. And then they delved a little bit into her life, and she'd had trauma, as all of us have, but she'd been relatively stable during that time. So no depression, no anxiety. And she'd been involved in accidents and just walked out of car crashes and things like that. So she had this excess. So that's why she's the most beautiful woman in the world to me, okay? She cracked it. Okay, so when people say there's no evidence for cannabis, well, actually, there is. And if I was to make a genetic person that I wanted to do an experiment on, she's already there. Okay. You're not going to get away with meeting an anaesthetist and not seeing some sort of diagram about how it works and what's going on. Okay, so that's just not going to happen. Normally, we have graphs and things as well, but Chrissy stopped me from doing that. So anyway. If you understand this, well done. But basically, it just shows that you have this, cannabinoids are produced very locally. They're not necessarily, they're just where they're needed. They're just produced. And when they're produced, they are broken down, as on many other molecules. But her anandamide is broken down by something you can see there called FAR. And her FAR enzyme was not working. That's FAAH. So I've done the easy slides. I'm going to hand over to Chrissy now for a little while. Here you go.
Can you hear me? Good. So we could go back quite a long way to talk about cannabis, but there really isn't enough time. So this timeline here is really just to show you an example of how we got from cannabis being seen as a recreational drug to something we write on a prescription. Initially, this really started around a paediatric journey. We are both primarily adult clinicians, so we will focus in this talk more on adult prescriptions and access. But we have to honour the families and parents of children with treatment-resistant epilepsy who brought much of this into the public eye for us. So back in 2017, families with children with treatment-resistant epilepsy began to campaign for access to medical cannabis, and potentially one of the most well-known, and people who have worked in the medical cannabis industry will be familiar with, Hannah Deacon and her son, Alfie. Hannah was living in the Netherlands at the time with her son, Alfie. He, without appropriate treatment, would have over 100 seizures per week. And she had to access medical cannabis for him in the Netherlands. And her story was really quite prominent in the journey. A petition was started, gained over 700,000 signatures, and a lot of media attention. Very soon after, Hannah met with the Prime Minister at the time, Theresa May, and asked for approval to apply for a Schedule 1 licence for her son. This licence was granted to Professor Mike Barnes, a consultant neurologist, and he went on to write this prescription. Shortly after, Sajid Javid, who was the Health Secretary at the time, announced a review in Parliament into medical cannabis. And it was moved from a Schedule 1 to a Schedule 2 drug under the Misuse of Drugs regulations. And just for those who may not be familiar with that, we kind of classify these in two ways. So the Misuse of Drugs Act 1979 will look at the potential harm of the misuse of a drug. And those are what we are familiar with as classes A, B, or C, for example. But the Misuse of Drugs regulations classifies drugs in schedules 1 to 5 in terms of the way that they're prescribed and who prescribes them. So that's why the Schedule 1 refers to the way that we prescribe, and it was moved from a Schedule 1 to a Schedule 2. Uncertified cannabis remains, or recreational cannabis as some will know it, remains a Schedule 1. We can only prescribe Schedule 2. So when it was moved, medical cannabis was then classed as a special, so an unlicensed medicine on a register of specials that is legally prescribed for any condition by a consultant listed on the specialist register. And we'll look a little bit more into what that means for patients. So as we talked about, specials are unlicensed medicines. We've talked a bit about what would happen if we licensed psilocybin or other psychedelics. Cannabis is a little bit different. It remains unlicensed. In the UK, it needs to be initiated by a consultant on the specialist register. They need to be happy that they have proof that a patient has a diagnosis. So that means that when we initiate treatment for patients, we need to have seen on their records, on their clinical records, that they have a history of this particular diagnosis. And we try to avoid making an initial prescription on a speculative diagnosis for patients. Guidelines tend to say, I say guidelines, these are recommendations, not necessarily set guidelines, that patients should have tried 2 or more otherwise conventional treatments for their condition before medical cannabis is considered. This actually can be a bit problematic. Whilst it gives us some safeguards, it does support a view that cannabis is seen as a last resort, that a patient must have had other failed treatments before we'll consider this as being valid for them. And sometimes that means that patients are then forced to try medicines that perhaps they wouldn't want to. So if, for example, a patient knew they would have chronic pain condition that would last for many years, but they didn't want to go down an opioid route, perhaps their own research suggests that that might not be effective for them. They didn't want to try those things first. It might still be very difficult for them to access medical cannabis in this system if they haven't already tried those other medicines first. So it can be a little bit limiting. Once that prescription has been initiated by a consultant, it can then be That's okay.
Yeah, I mean, it comes down to the consultant that does see the person in order to decide what is the best course. So these are guidelines. They don't have to be instigated. So that discussion will happen between, say, me and you're like, oh, I don't want to do that, I don't want to do that, and I will agree with you in that sense. So it's not that it is enforced, it's a recommendation.
So that's okay. So this lady was just saying that this would force patients to have medicines that have otherwise significant side effects for them. And we were just clarifying, as we were saying, that these are recommendations for practice, and whilst that can be limiting in some situations, when you speak to your initiating consultant, you will have a process of discussing what your priorities are, where you've been. So whilst they are recommendations and they can be limiting, we do sometimes have to work outside of that box for the complexity of our patients, basically. We are looking, so whilst patients can access this through and through their consultant, it's initiated by their consultant, it is then prescribed or can be prescribed under a shared care agreement by another registered clinician, say like myself, who is registered to prescribe a controlled drug off licence. And that shared care agreement means that if I'm looking after my patients and I'm reviewing their medications, if I want to change that prescription, or indeed I'm concerned that the treatment isn't effective and I want to recommend a change that we haven't otherwise discussed, I have a continuous multidisciplinary process with a team of consultants so that I can go back, discuss my case and adjust the treatment for the patient. Sadly, in terms of adult prescriptions, even though this changed in 2018, less than 10 adults have ever had their medical cannabis funded on the NHS. I am a clinical strategist in chronic disease, so I could do a whole other talk on those barriers, but there isn't quite enough time for that. So patients are forced to access cannabis from the private sector at the moment. That is still regulated by a number of ways. The CQC regulates those clinics like it does an NHS-based service. The MHRA, again, regulate us in the same way. But this growth of private medical cannabis industry without some of the same standardisations or standard operating procedures that we might have in the NHS has meant that there can be some inconsistency between the way that the care is delivered between clinics or pricing, for example. And we still have continued barriers to equitable access and standards, standardised treatment. There is still a lot of stigma. There's still a lot of clinical distrust from other clinicians, although that is changing. There are some evidences of poor practice. There are some evidences of fantastic practice, but we have to be open to discussing both and learning from both. And there can sometimes be a lack of integrity in the way that patients can access it or the way that we discuss it.
And I can reassure you that all the best practices come from us, yeah. How many patients have accessed this? For Timmy, that's probably a really good question on what sort of happened. So we're up to about 50,000 patients. And NHS data, when we write a prescription, it's a special one. It's on a pink form. And on that pink form, it gets stored because it's a controlled drug by someone in Leeds or something. And they've issued some numbers about how many prescriptions have gone through. And between 2022 and 2023, I think there were 150,000 prescriptions that were born from doctors or healthcare professionals afterwards. And that's due to, they anticipated that doubling between 23 and 24. The data is about a year out anyway, so we'll probably get that soon. But what it means is that it's expanding a lot. And there were initially, there was about 10 clinics at the start. There are a lot more coming. So we're up to 40. I think we'll probably double that by the end of this year. But the number of prescribers isn't growing that fast. You've got another medical director over there of a clinic, and the model's sort of changing. At the beginning, it was just totally consultants. You'd see a consultant, and they would follow you up and continue. Now you'll see a consultant, and then you'll be handed over in a shared care capacity. I think somebody in primary care was talking over there, to either a GP, a pharmacist, or a nurse. So all those practices are actually happening right now with those particular medications. And the number of medications is just getting huge. The number of flowers, the different variety of oils, suppositories are coming, pastils are coming. So that sort of, what has been available in the recreational market is now coming into the medical market in a much more stronger way. So it's going to be growing, and we'll be able to pass on some lessons, and we'll probably maybe talk about that as well.
So we've talked around legislation and changes, but one of the things we wanted to present to you was what it's like working with the medicine once you can start writing it on a prescription pad, and how that's been as clinicians as this has evolved over a few years, and some of the experiences that we have. So I wanted to give you a brief case study of a patient that I've worked with. And the reason I've chosen this lady is I think that sometimes we have a perception of the kind of patient that a medical cannabis patient might be. And I wanted to present this lady to you to show just how much we can do with medical cannabis. I came to this because I believed in it. I work with multi-morbidity chronic disease patients. That's what I do. And I really was tired of filling patients full of lots and lots of complex medicines that caused more problems each time we added another thing to it. And I wanted to find a way to help patients reduce the amount of medicines they were having, for example. And I found that actually the kind of patients I ended up seeing were very complex and perhaps not who we'd expect. So I'm going to call her Mrs. A. Now, Mrs. A was in her late 80s, maybe early 90s, what we would call cannabis naive. She'd never tried cannabis in her life, never been prescribed it. And she was a lady in quite advanced state of dementia. She was very loved and looked after beautifully by her family. In fact, they lived just a few doors away. They were quite a wealthy family. They were able, when they weren't there with her, to afford really great and wonderful carers that I got to know as well. So she was never on her own. She had a beautiful home and lots of people around her and great care. But her main issue was night terrors. And I don't know, perhaps people who have seen night terrors in a patient with dementia, they are truly distressing. She would wake screaming for hours in the night, to the point that the neighbours were quite distressed by it too. It was very difficult to contain it and to manage it. They tried as many things as they could, but everybody was really very deeply distressed by the situation. She started to be given eventually many things, but she was reliant on lorazepam to go to sleep. And this really was meant to be for those really difficult nights. But when we first saw this patient to prescribe for her, she was needing lorazepam every night. And the knock-on effect of that was that the next day she had sort of lingering effects, and she was less able to enjoy the quality of life that she would have in the day when she was much more settled and would otherwise have a much nicer day. The family were really quite distressed about medicating her so much at night. They felt that they were really just sedating her, and that felt, well, would never feel like a nice thing to do to your loved ones. So we started to work with this patient with a very low dose balanced oil. And once the consultant was happy with her initiation of treatment, I worked with her for a long time. And I would titrate her cannabis doses up and her lorazepam doses down. And sometimes that was going really well. Sometimes we had to take a few steps back. It's very rarely black and white. But eventually, after around about 4 months, she was needing lorazepam maybe once in a month or twice in a month. And she was taking a dose of medical cannabis oil, a balanced oil, before bed, 2 hours roughly before bed. We did have to move the times a number of times as her own circadian rhythm kept changing as to when she would sleep or not sleep. So we had to get a little bit creative about our timings sometimes. But actually what we found was that she responded really well. It wasn't that she never had any more night terrors, but the frequency and severity of them decreased. And when she did wake frightened, we were able to settle, her family were able to settle her without sedation. And it made a really big difference. And the reason I've chosen this patient is that I wanted to talk to you about complexity. That patients aren't always straightforward. Sometimes they take a lot of our time. And that is relevant because when patients are reliant on this in a private prescription, in private practice, that service has to be cost effective for those clinics. It has to be profitable. Otherwise, they're not going to do it and no one gets access, right? It's not perfect, but this is the only way at the moment that many patients get access. So we need that to happen at the moment until we can change things for the better or change things in another way. But that means that those clinics, they do have to make profit to keep going. And it also means that as competition grows, that becomes harder. And as the industry grows, that becomes harder. Clinician time is expensive. So the longer a patient needs to see us, the more expensive that process is. And sometimes that can mean that complex patients are maybe not so much screened out of the process, but it's harder to accommodate the care of those patients in this current paradigm because they take a lot more of our time. And that is what we love to do, but we also have to acknowledge that it is complicated and expensive. So those are one of the challenges in access. One of the other challenges in access, and I think my colleague in the back there will relate to that, is primary care infrastructure. So I'm a fellow in population health management. I help to design at board level the way that we manage chronic conditions in our locality, in my case Cornwall. And that means that when we decide something becomes available as a treatment, I work with what does that look like in clinic? What does that look like when we see the patient? What infrastructure do we need? How long will that take us? Do we need a shared care agreement? What's that standard operating procedure going to look like in primary care? How are we going to train our GPs and nurse practitioners to prescribe that? What are the competencies? Do we have the workforce? How long will a consultation be? What do we have to tell CQC when we change our registrations? And at a time in primary care where we are working really hard to manage lots of very, very difficult changes that are about to come our way, it's very difficult to make that process. When the rules around cannabis changed in 2018, we got hit with COVID very quickly after. So our primary care infrastructure changed again. We've had a lot of change over the last 5 years particularly. So those challenges again affect access. There are, I think, some other challenges Sunil was going to...
Yeah, I'm gonna wrap this up a little bit quickly so we can take some questions. But the challenges that we've had have been both political, and I think Timmy's outlined this a little bit earlier, that despite the politicians think they've done their job. So they've allowed it to be prescribed, problem gone, move on. And that's not the case because people still aren't getting access. The other problem are other professionals, and trying to engage with Royal Colleges at an early stage is also really important. The Royal College GPs, we've tried to have meetings with them, they're not interested. They've got enough problems at the moment that they're not engaging, and nor are the other Royal Colleges at the moment. So then trying to get other prescribers to come in, to support them, to say this is the right thing to do, we're doing it in the right way, let's follow this, it's been very, very difficult. And then there's still a social stigma about it as well. People won't tell their partner that they're taking this. They won't tell their family they're taking this. They're still hiding it from their own relatives about it, which just seems really crazy to us. I mean, we just thought we'd take that on board as well. So we were going to give some top tips to Timmy, but he's already done it, so it's really difficult, so thanks for that. But I think what we need is it's that MDT structure. It's having the SOPs. It's having the infrastructure in place in order to scale this, to use a business term, to move forward. But getting more patients access to this. So, is there anything else you want to say, Chrissy, or should we take some questions?
I think you've covered it. Just this is a multidisciplinary thing, and it's not perfect. So we often think that something becoming licensed is the end. We've achieved it, but actually, it's really just the beginning of how you deliver it. And those are our challenges. But that is multidisciplinary. It means working with industry. It means working with clinicians, patients. It means that understanding the cultural impact, the spiritual impact of all of these medicines.
Right, and with broker convention, we're introducing ourselves at the end rather than at the beginning as well, okay? So.